Good evening, everyone. You are welcome to this month's edition of monthly clinical meeting of the Nigerian Society for Colorectal Disorders. And today, we're going to have two sessions. And the second part of the meeting this evening entails the panel discussion on the theme of the day, that is the role of our multidisciplinary team in the management of colorectal disorders. And as you can see, we carefully crafted the topic. We didn't say only cancers, but we know that majorly cancers, but we want to see how we can bring in multidisciplinary management in the management of colorectal disorder. I think by and large, to a large extent, people will be talking on the colorectal cancer as a case study this evening. And one of our lead faculties will be having a case presentation to enrich that panel discussion. This evening, we have a lot of faculties who will be participating in the panel discussion, among whom include Dr. Olujimi, who is a senior consultant and general surgeon, and he also doubles as the president of the Laparoscopic Surgery, president of the Laparoscopic Surgery Society of Nigeria. We got Mr. Mukhtar Ahmad, a consultant colorectal surgeon, and also doubles as the colorectal MDT leader, University Hospital, Dorset in UK. We have our radio oncologist, Dr. Nwamaka, Lasebikan, all the way from University of Nigeria Teaching Hospital. Professor Chukwudi Okani, is a pathologist from Chukwuemeka, Odumegwu, Ojukwu University Teaching Hospital in Awka, Anambra State. And we also have Dr. Olufunmilola James, who is a consultant radiologist at Lagoon hospitals in Lagos. So these are the people that we coordinate the panel discussion during the second session.
Yeah, thank you very much, Professor Dejibo. And well, Mr. Mukhtar doesn't need any introduction to this audience. He's a brother and friend of the society. So Mukhtar, over to you.
Thank you very much, Mr. Koka. So for those who don't know me, I work in Dorset on the south coast of England as a colorectal surgeon and lead clinician for the department. I was MDT lead for 6 years before I had to hand it over because I had too much on my hands. It's an honor to be invited, so thank you very much for asking me back. It's a topic that's close to my heart. Apologies for those who've heard me talk about this before. And I visit Nigeria quite frequently. I go to many units, and it's something that I am keen that we invest a lot of energy into. I deliberately focused on colorectal cancer, and I'll briefly explain why. My experience working in some centers that have adopted MDTs in Nigeria is that and the history of MDT starting in the UK in earnest, which only just goes back to 3 to 4 decades really, is that when you build the cancer MDT, that model can easily be rolled into non-cancer work, into benign work. So it's important in the context of 20 minutes to 45 minutes that we have today. If we tried to extend into all the different MDTs, we wouldn't be able to focus very much. So I have no disclosures to make. This is my base hospital, the University Hospitals Dorset and Bournemouth. I also work at Poole Hospital. And the outline, I was going to talk about the role of the MDT. What does good look like? How we can streamline the case discussions, standards of care, overview of staging. I have a few scenarios, but I'll focus on one which is a live case that we discussed in our meeting just 3 days ago. I'll talk about barriers to efficient MDT functioning and how we can monitor performance as an MDT. I'll skip through the first for football fans. You'll be aware about teams and for the last World Cup and seeing how you win and lose together as a team. And that is the one of the key barriers I've found in MDT functioning is the fear of being blamed or being or feeling that other people are trying to, in quotes, steal your success. But if you win and lose as a team, that takes away that pressure. So the other thing that I have, you know, that I've reflected a lot about is how much effort animals, the smaller animals, insects like the bee and ants, put into working together. And I didn't know this till quite recently, that a bee produces less than a teaspoon, a 1/12 of a teaspoon in its entire life. And, you know, the amount of honey that we put on our breakfast or, you know, other desserts and meals, 12 bees, it's taken 12 bees their whole lives to make that teaspoon. But if it weren't for their team spirit, we wouldn't have honey. And this picture sort of exemplifies what a team can do together, almost make the impossible possible. So the other MDTs that we could talk about, possibly another time, the inflammatory bowel disease MDT, pelvic floor and functional bowel disease, which I participate in, and complex polyp MDT, and then the AIN and complex proctology MDTs, all of which exist in our institutions. Some are regional, and they would exist all around the UK, and I suspect replicated around the Western world. Indeed, in Kano, we have recently started a pelvic floor MDT after instituting a cancer MDT with some success. There are still challenges, but we're making some progress. And it just, you know, this slide just shows sort of the things that MDTs consider together, you know, the questions that, you know, you pick up from some of the words, the questions, the terms that keep coming up in meetings. You know, but the key thing together, the learning together, is about collective memory. You learn together, you pass it on to the next generation. You complement each other, you learn a standard way of speaking and communicating. There's a shared language. We try very hard not to propagate individual agendas. You know, surgeons, particularly by nature, type A personalities, often, you know, with significant egos. Otherwise, you wouldn't be a surgeon if you didn't have an ego at all. But thankfully, the MDT, because there are many specialties there, we complement each other, and those egos are moderated. So going on to talk about, I wanted to make a special plea about the role of the nurse specialists, the clinical nurse specialists, otherwise in some settings called the cancer nurse specialist. And this is a person who's an advocate for the patient. They're usually a senior nurse or mid-level nurse who's undergone some training and become quite proficient in discussing the patient's diagnoses with them, supporting them psychologically, and also just through the course of their treatment. They oversee surveillance in some settings like ours. They're huge advocates, and they make sure that everything's ready for the meetings, working together with the admin support. This is a really important team member to invest in. So our MDT has this breakdown, and this will be replicated all around the UK to varying degrees, depending on the center that you're in. You'll sometimes have your hepatobiliary and your thoracic surgeons on site. We don't, but they're linking, and we have access to, you know, to all the specialists that we need in different areas. COVID has brought about virtual MDT meetings, which are really fantastic. We now have gone back to a hybrid meeting where we have 2 rooms on both our sites for people who want to be physically present, but we also have a life-size link for colleagues who are working from home or who are unable to get to that room where the meeting is holding. And, you know, what is the role of the MDT? We've sort of touched on it at the beginning. But the key thing is to establish clear treatment protocols, either to adopt local, regional network protocols, adapt them to your your area of interest, because we all have different populations, different challenges, and to define the roles of its team members, agree working governance protocol, discuss every new diagnosis of cancer, and review known cases where there's a change in the treatment plan. And there's good evidence that where MDTs have been introduced, that the quality of care has improved. Many MDTs in low and middle income countries are linking together with sister MDTs in other parts of the world to gain from there, to learn together and improve the quality of care we deliver our patients. So we have a structured referral system, which is something that I strongly recommend, to have a clear referral form for new patients, because that helps the referrer to provide the relevant information to the MDT. And the meeting should be flexible to allow time for discussion of the more complex patients. MDTs should agree standards of care, where straightforward cases could be added to the MDT for noting, rather than discussing at length treatments that are on the whole standard. And anal cancer often lends itself to this, because there is a standard of care for the different stages of anal cancer, and only a small group within the MDT would have a subspecialist interest in these patients. So the checklist for discussion, and this would vary depending on your setting and what is available. Note where I've included PET, it's plus minus, it's not mandatory. It depends on the findings on the other investigations. But particularly for rectal cancer, the guidelines are to discuss rectal cancer patients when you have histology and MRI available. Otherwise, we might make the wrong call about what treatment they should have, and we'll come to that in one of our cases later on. And the standards of care, where the MDT agrees that certain cases do not need a full MDT discussion, it should be very clear when you do the triage meeting in our MDT, the clinical meeting, the full meeting holds on a Thursday, but the MDT lead has an initial triage meeting with the nurse specialists and the facilitator, who's an admin support for the MDT, where you look at the whole list, make sure that you have everything required for the meeting, so we don't waste time on the day. And there's certain cases that could be put down for noting. There might be patients who have passed away while they've been waiting for, while they were being processed, but they probably had advanced cancer and were palliative. So those cases we don't need to look at the scans in detail. We just need to document on our system what stage they were and move on to the next ones. And I won't belabor this. This is a slide that many of us will be familiar with, but as an example of a standard of care. So the complex discussions are often around early rectal cancer and the different treatment modalities that might be available, recurrent colorectal cancer, particularly recurrent rectal cancer, where the treatment's often quite complex. Metastatic disease, where there are new treatment options, immunotherapy, lots of trials going on. And I mentioned earlier that some MDTs have a separate complex polyp MDT to discuss the best approach for large polyps that are at significant risk of harboring cancer but have not been proven to be cancerous. And then the staging, this again we'll all be familiar with, but I just put it in my presentation for completeness. So I'll skip through these slides so we can focus on the clinical presentation. So the additional data set that is required when documenting the outcome of discussions for these patients include the circumferential resection margin, the distance of the lower edge of the cancer from the anal verge, because this has an important bearing on planning treatment, the presence of EMVI, the proximity of involved lymph nodes to the resection margin. And the treatment options, in a sense, colorectal cancer is relatively straightforward. The options are not that many. There is including, apart from ablation, there are other modalities of treating micrometastatic disease, but I haven't put them here not to clutter the slide. But it usually comes down to which order of these treatments we're going to adopt. So I'll go to the case presentation. So I'll start with this one, and then I'll skip to the last case. Unfortunately, I wasn't able to anonymize the dynamic images, so I could share them with our radiology colleague, Dr. James, and I was concerned that if I tried, I was going to share them on here, but again, I couldn't get it to work, and unfortunately, I left it too late to get our PACS people to help, so I do apologize, but they'll only be still images. So this first case is a 35-year-old male that presented with bloating, abdominal pain, and was FIT positive. He had a CT scan which showed a locally advanced transverse colon cancer. There was no metastatic disease on his staging CT chest, abdomen, and pelvis. He had a colonoscopy which stopped at the level of the cancer because it was about to obstruct. Histology came back to a moderately differentiated adenocarcinoma, and he was MMR proficient. And you know, this slide is sort of trying to replicate what people might have been thinking around the MDT table when we were discussing it. You know, often there will be a surgeon who would pipe up to say, well, it's resectable, why don't we just take it out? The nurse specialist is thinking, you know, will he cope with treatment? You know, thinking about the psychological state of mind, his job, his family. And the oncologist might be thinking, he might be suitable for one trial or the other, or the research nurse, or thinking about neoadjuvant chemotherapy. What's the MMR status? Can we downstage this? The interventional radiologist might be thinking, this potentially looks stentable. Could use stent it and then give neoadjuvant treatment. So a few things going on through the mind. So I'll skip that. It's just so I don't talk about exactly what we did on that case, and I'll go to the fourth case, which is the live case at the moment, and then I'll leave to the panels to probably posit what we might do. So this gentleman, 75-year-old, he was seen by one of our nurse specialists in what we call a fast track 2-week wait clinic for urgent suspected cancer referrals. His only past medical history is atrial fibrillation, for which he was taken a doxaban. He's got BPH as well. His history was of tenesmus and rectal bleeding. He had a colonoscopy, which showed this lesion about 2 centimeters. It was felt from the anorectal junction. You can see the retroflexion here. The tumor doesn't quite invade the anorectal junction on there, but quite close. He had a CT scan, and this slide shows the only area of interest where there's this lesion in segment 6 of the liver that will be clarified with an MRI. That will be clarified with an MRI scan. And then he had MRI of the rectum, which you know, showed locally advanced, very low tumor abutting, but not invading the anal sphincters. You can see here quite close. You can see the levatus. You can see the external sphincters coming in. It's close to it, but not invading it. He's got a big prostate, as we know. It's quite low. You can see where it is. You can see its relationship with the sphincters. It's lying right on the pelvic floor, but there's a clear plane. I'm speaking out of turn because there are radiologists on the call, so do feel free to shout if I've said anything that is that doesn't represent what's on the slide. There is a hand up, so feel free to butt in and ask if it's a question relating to the slide that we're on. There's a hand up from
yes. Ojukwu, you have your hand up. Do you want to unmute, please? Can he unmute? Okay, do you want to type your question in the chat box if you cannot unmute, please, Kenechukwu?
Okay, thank you. So again, on here, we'll talk about this later, but this is node as well, just sitting on the resection margin of the sacral promontory, which is of interest. So the issues we have here, it's staged as T3B, it's N1 MX because we haven't clarified the situation with the liver. The CRM is threatened, it's abutting the sphincters. So we started to think about if this came to surgery, what could we do, a restorative operation, or is this would this have to be a non-restorative operation where the sphincters come with the specimen? The presacral node is a concern in planning treatment, either radiotherapy or the surgical treatment, and what do we do with the liver and what sequence does that follow? Just in the last, because I suspect the discussion will go on if the chair is happy, I will skip to the last few slides, which focus on the barriers to MDT practice. And often people talk about resource, time, having the relevant specialists. I know there is a survey that will be shared later on, which will be instructive in terms of whether there is actually paucity of specialists or whether it's the other factors that that determine the low uptake of MDTs in many parts of the lower and middle income countries. And the resource, there clearly is a disparity with resource. So I've compared Dorset, which has a population of 700,000. And we have 7 oncologists who have an interest in colorectal cancer. We have 17 colorectal surgeons based in 3 hospitals. We have 8 GI radiologists, 9 nurse specialists, 7 stoma nurse specialists. And this is the situation in Kano. There might have been some change with the general surgeons with a colorectal interest, 2 oncologists on the whole, 5 radiologists, but that have expressed GI interest, but none that is actually differentiated, if you like, into becoming a GI radiologist. To the best of my knowledge, there are nurses who have some knowledge of stoma care, but haven't attained qualifications or dedicated training in stoma care. And there are definitely no cancer nurse specialists. So strategies to overcome these barriers, exchange programs, and as I said earlier, fantastic to see the ACP-GBI take an interest in the Nigerian society, virtual MDTs, leadership training. This is really important. So in the UK, MDT leads have access, and leaders, clinical leaders at all levels have access to leadership training, which is vital to learning how to lead the team, not just within the meeting, but to achieve the outcomes that are desired outside the meeting as well. Developing guidelines and learning together. Collaborations, there's so many good examples between different countries. These ones are Cameroon and Leeds, Malawi and Edinburgh, that have been shown to have improved the quality of care. And they don't cost anything to set up. We just need the interest, and we need propagators, people who are willing to drive this. And in terms of performance monitoring, audit, annual reports, we hold annual general meetings where we examine our performance as a team. We have internal, external peer reviews where other MDTs, not necessarily colorectal cancer, coming to observe our performance, look at our data, and give us feedback. We collect patient feedback as well. And key performance indicators are things that every MDT should collect, starting from very simple things that are easy to collect, like mortality, like anastomotic leak rates, and then building up. And it's something that the society and the colleges in Nigeria could work together on to agree what are the realistic performance indicators. And I know that Mr. Coker and colleagues have worked hard to modify guidelines that are designed for the Western world to make them more pragmatic for Africa. The minimal core data, so each team should agree what they need to collect as for each patient that is discussed, so that you can go back and refer to it. And the learning, it's difficult to reflect during a busy clinical meeting, so time should be made to review complex cases, either through a dedicated complex pathway patient review, which our MDT has, or through the mechanisms of clinical governance meetings that exist, and then multi-source feedback for the individual members of the team as well. So in summary, clear criteria for MDT discussion, clear documentation of the outcome. There should be clarity about the quorum for the MDT. Our meeting has clear criteria, and there's national guidance in the UK about what constitutes the minimum number of people from each specialty that can make decisions to cancer, colorectal cancer MDT. This will vary from institution to institution as centers in low and middle income countries develop their systems and annual reports, and building collaboration with centers in other parts of the world that are more advanced in their MDT journey. So thank you. That's the end of my presentation, but I'm happy to go back to the slides to discuss those cases, that the 2 cases. There are 4 cases in total. If we wanted to do more, we could do more, but I presented just the first and the last cases.
Yeah, thank you very much, Mr. Ahmad, for that excellent presentation, and more importantly, also for. So we have 20 minutes now. So I thought it would be useful if we talked about the transverse colon lesion and the rectal lesion, just perhaps 5 minutes for each, so that we should still have some time to discuss, because I know that there will be a number of questions that people may want to ask. So the transverse colon cancer, you said it's locally advanced. I don't know if Dr. James, I know Dr. James, you cannot just comment on one slide. I don't know whether you want to make any comments about this CT scan image.
Yes, thank you, Dr. Coker. So we're just looking at one image. So yes, it's a bit difficult to make that assessment. But when we are evaluating a tumor in the bowel, and we're talking about whether the tumor is locally advanced or not, what we are basically looking at is the relationship to the surrounding structure. So if we look at this image, I don't know if it's very clear. So we see that large bulky tumor right there. Okay, thank you. Yeah, so you see the wall thickening. And if we look in the fat around the tumor, which is the darker areas, you can see what the radiologists describe as stranding. And in some areas, there are some small nodules around the mass there. And also in the anterior aspects, right there, you can see that there seems to be loss of the fat plane right there with the rectus muscle on the right side. So all these features, you will also check, are there any peritumoral lymph nodes? What's it doing to the surrounding structures? The fat planes, are they preserved or are they lost? So those are the features that we look out for to let us know that this is a locally invasive malignancy.
Okay, thank you very much. Well, from a surgical perspective, I mean, ideally, this will have been one that one will stent and then refer to the oncologist, but I am only aware of 2 places or 2 people who stent colorectal lesions in the country. So majority of people will have to think of an alternative. And the challenge here, of course, is that it is locally advanced. There are a number of options, and it is impassable, so there is an imminent risk of obstruction. So one cannot prevaricate here. If this were my patient, I would stick in a laparoscope, first of all, just to see whether, this is resectable. But if it is not resectable, then one may need to defunction this patient and then refer for neoadjuvant chemotherapy. You did say that there was no evidence of metastasis. Am I right? Distant metastasis. Yeah.
Yeah. Disease,
so,
yeah.
I think I don't know if the pathologists, the other members of the panel have any questions or comments on this first case. So what did you do, Mr. Ahmed? What did your MDT do?
Yeah, so if I go back here, so again, we had, quite a vibrant discussion, particularly because he's young. We didn't want to go in and exactly as you said, Mr. Koka, some of my surgical colleagues suggested, why don't we laparoscope and see whether that plane anteriorly on the abdominal wall is actually, invading the abdominal wall or not, whether you've got enough mobility to resect it. Posteriorly, the duodenum seems to be spared, which is sort of one of the important questions we ask our radiology colleagues at the MDT, and because you can sacrifice a significant part of abdominal wall safely and get a margin. The oncologists were keen that we tried to give him some neoadjuvant treatment because he was MMR proficient, to give him, so he was considered a good candidate for the Foxtrot trial, but the trial that he was particularly suited for was not open in our center. The patient wasn't keen to go elsewhere. He wanted to stay, locally close to his family. So they managed to give him the same, what he would have been given on the trial, but out of trial. He had 2 cycles of chemotherapy and unfortunately came in just after receiving the 2nd cycle with a local perforation. And he then ended up having a resection and the two ends brought out. He's now recovered and is now having adjuvant chemotherapy. So all the discussions went back. We discussed stents. The radiologists weren't keen. They thought the configuration of the cancer would make it tricky, particularly because you couldn't give him bowel prep because he was about to obstruct. They felt that it was unlikely we could get a scope to the cancer and get a clear enough view for them to pass a wire through the scope. We considered we suggested an ileostomy to the patient before chemotherapy, but he was dead set against it. He wanted to take his chances, in his words, of not obstructing on the chemotherapy and only having a stoma. He absolutely needed it, which in the end is what happened.
Yeah. Thank you very much. Mr. Eguare has his hand up.
Yeah, thanks very much, Mukhtar. I think that's a very interesting case. In fact, you just answered my question at your last comment that the patient was dead set on not getting surgery, because I would have thought this patient that presented with bloating, pain, and then impassable tumor, those were, signs that this was an impending obstruction.
Absolutely.
Knowing that, and if you embark on neoadjuvant treatment, that was going to and lasts for at least 3 months before you do anything, which in this case, it was obvious that, you may have to abandon treatment to intervene, which was what eventually happened. So, but my question then is, in the setting of an MDT, does the patient's desire not to have surgery, did that impact your decision?
It did in terms of he was keen to have resectional surgery to get rid of the cancer. He just didn't want an ileostomy before starting, because even though he had all these signs that are warning signs, as you rightly said, he was managing to eat, he was still opening his bowels on a low residue diet. So he wasn't clinically obstructed, but he had the symptoms that would suggest he wasn't far away from becoming obstructed. And in the end, he didn't actually obstruct, he perforated. So he, because I suspect partly because of the obstruction is why he perforated. But he didn't want, and, we presented the options to him, said we could try a stent, but our radiologists weren't keen. And our advice would be an ileostomy. And I'd certainly come across quite a few, because if you look at, and it always bears on your mind a 35-year-old, with 2 young children, that's just been told they have cancer. There's all of that to process, and now you want to give them what he called a poo bag, in addition to everything else he was trying to cope with, and he just felt, well, I don't need this at the moment, and I'm willing to take my chances, which unfortunately didn't quite work out for him.
Did you have any thoughts at all about the ileostomy, thinking that what if he had a competent ileocecal valve?
Yes, it's always an important consideration about ending up with closed loop obstruction. So I suspect many surgical colleagues do the same. I generally try to intentionally rupture the ileocecal valve by passing a balloon, passing a catheter into the distal limb, inflating the balloon and putting it back, doing it a few times to try to make it incompetent. I'm not sure, there's no evidence base that suggests it definitely works. People have all sorts of different techniques. I have done cecostomies for these patients in the context of a full-blown obstruction. It's not a nice stoma to have or to look after, but as a bridge to getting someone through chemotherapy and to surgery, certainly works well. But it's an important thing to look out for and to warn the patient and the allied health professionals looking after the patient that you can still obstruct with an ileostomy if you have a competent valve. So if the patient continues to complain of pain, we should have a low threshold for repeating the CT scans and checking that their cecum isn't starting to distend.
Thank you. Professor Ade has his hand up.
Thank you, sir, for recognizing me. Thank you, Mr. Mukhtar, for the presentation. Just wanted to ask, based on this patient's age, 35 years old, with early onset colon cancer, what are your thoughts about risk factors, predisposition in terms of genetics? I know he was MMR proficient, if I'm correct, but right. It's still worrisome to me that such a young patient with this kind of disease, we may be dealing with something in the background.
Absolutely. So yeah, really good question. Thanks for that. So in our MDT, and I suspect most MDTs here under the age of 50, anybody with colorectal cancer is referred to the genetics service, and they would do more in-depth tests and take detailed, we'll send them a family history questionnaire, which they fill out. And they're certainly their near relatives, their first degree relatives, will be offered screening at near the age that they developed their cancer, regardless of whether they were MMR proficient or not, just purely based on the age, because there will probably be undiagnosed, genetic abnormalities that have led to it. Sporadic cancer at 35 is not common, so they all get referred to the genetic service.
Thank you very much. In the interest of time, I think we ought to go promptly to the a second case now to have a look at that, which is quite an interesting case. How old was 75 with fibrillation, BPH? Okay, because I was wondering then what his comorbidities were.
Yeah.
So this is a gentleman with what looks, you didn't tell us whether the MRI was also suggestive or the PET CT suggestive of confirmed liver mets?
So he hasn't had a PET, so what he's waiting for is an MRI scan. So this case only came to the meeting on last Thursday. So he's going to have an MRI of his liver next week, but the radiologists are suspicious that this lesion in segment 6 is metastatic deposit, which would be entirely in keeping with a big bulky rectal cancer with visible lymph nodes on the rectal MR. So this is yet to be confirmed, but I put the case, we could discuss it on the assumption that this lesion turns out to be a liver metastasis.
Right. So he's had, I mean, we have the histological confirmation, don't we?
Correct, yes. So he's definitely
invasive carcinoma.
Yeah.
Just that you said it's quite low, so one needs to be sure that it is indeed invasive adenocarcinoma.
Correct,
Dr. Lasebikan, you are an oncologist. How should we tackle this problem?
Okay, thank you, Dr. Kuka. Just to say that I agree with the previous case. I was actually about to make a comment when you kind of like rounded up on saying that like the oncologists in their team, I would have just said, you know, give chemotherapy a shot first of all. So, but back to this case, I mean, considering the patient's comorbidities, I think it would be good to know what the performance status is like and discuss with him. We, with the suspicion of that solitary metastasis, I think that he would be best served with perhaps maybe upfront chemotherapy, but with the bulky nature of the lymph nodes and the rectal bleeding, perhaps maybe a short course radiotherapy and then have sequential chemoradiation with a short course radiotherapy and then following up with chemo. Again, that would be based on the performance status. I know that we've seen the comorbidities that he's had, but I don't know how stable he is and all of that. Another thing to consider would be if that liver metastasis is solitary, the skill sets that are available over there, perhaps maybe if they would also consider a metastectomy, for instance, considering it's stable. So these are the things that, again, the surgical colleagues will be able to answer. But first off, I'd say that he would most likely benefit from sequential chemoradiation because the disease is bulky. There's hints of metastasis at the time as well.
Can I just clarify? So when you say sequential chemo, are you talking about total neoadjuvant treatment where you have a full course of chemotherapy followed by chemoradiation?
Yes, so that's why I said sequential, perhaps offer him a short course chemoradiation upfront so that we can immediately go into having more systemic treatments immediately. And like you said, TNT.
Yeah, you wouldn't start the systemic treatment first of all before the...
If it's a short course, it's just like 5 days, you know, so, and then we just go on straight onto it. Reason being that they said he had rectal bleeding and then with the bulky nature of the disease, see whether that can shrink it a little bit.
Okay. I think Mr. Eguari has his hand up.
Yeah, just wanted to say I agree with the oncologist, particularly because this patient is on the anticoagulation and having rectal bleeding. I think a short course of radiotherapy to temporize the symptoms will be advisable. And because this is a very low tumor, stenting is out of the question because it's just going to create trouble for this patient. Tumor, which is about 2 cm from the anal verge, and it would just not be amenable to stenting. But starting with radiotherapy to temporize the symptoms will be the ideal thing, and then go on to neoadjuvant chemoradiotherapy to downstage this tumor before you can restage the patient. for possible resection. But again, we have to be cognizant of this patient's comorbidities of atrial fibrillation, which makes him a very high risk. Even again, subjecting this patient to neoadjuvant chemo, radiotherapy, some of these patients we develop exacerbation of their cardiac pathology as a result of the chemotherapy. So it's quite a conundrum to treat this patient, but we agree with starting with the radiotherapy to temporize the symptoms.
Yeah, I don't think it's obstructing from, if I remember, so probably the stent wouldn't even have come in, hopefully, for discussion. And certainly, like you said, 2 centimeters below the anal verge is much too low for even one will struggle with 5 centimeters to stent. So Professor Okani has his hand up.
Yeah, thank you very much for this presentation. I wanted to ask if, for example, this patient coagulation profile is known, and then that not a candidate that can't biopsy, that liver biopsy be done, CT-guided liver biopsy, so that one can know, since it's a guesswork, the radiologists are still not certain whether that is a metastatic tumor. I think putting a needle there to guide when everything is at least, if the coagulation profile on that thing, other indices are known, a needle can be put in there through CT guidance, and then a biopsy will be taken, and then the proper diagnosis will be made. And I think it's the easiest thing to do, this type of setting. Very straightforward. Liver biopsy, very straightforward.
The liver surgeons will frown at that because there are other ways that one can. Certainly an MRI or even a PET CT will be able to help better because should this patient require resection, then often they're concerned about seeding of the metastases with such needle interventions. What will your liver surgeon say to sticking a needle in, Mukhtar?
No, absolutely, as you said, Mr. Koka. So it's an important question Okani asks, and I get asked this a lot as well when I travel around in Nigeria, and I think things have evolved as well here over the years. And as Mr. Koka has answered the question perfectly, first, radiologists have very high confidence levels of calling a metastasis on an MRI scan with huge accuracy. It's very rare that they are wrong. There are other modalities like contrast enhanced ultrasound. There is PET CT, which will tell you clearly this is an avid lesion, it's a MET, and the liver surgeons, this lesion, if it turns out to be a solitary lesion, could be resected by laparoscopic metastectomy as a day case procedure, and that could downstage this patient from being a stage 4 cancer subsequently. So it would the context in which you can biopsy a liver lesion is where the liver is unresectable. So if a patient presents with a liver stuffed full of metastases and a colon cancer, rather than subject the patient to a colonoscopy, you could biopsy the liver to confirm that it is indeed a colorectal cancer. But if the liver is potentially resectable, then it is best to avoid putting any needles in it.
All right, thank you. Dr. James, you had your hand up.
Yes, thank you. I had a question for Dr. Mukhtar. Aside from the pesecal node, were there any other lymph nodes, pelvic side wall?
Yes. Yeah, so again, apologies that I couldn't send you the full slide. So there are I'll see if I can show you. This slide doesn't show it very well. Let me see if I can enlarge it. But there are multiple nodes within the mesorectal pack, like that one and this one and that one as well, that are close to the CRM that in themselves could potentially result in an R1 resection. The one that was particularly of interest, but we felt surgically that it would come out at the time of resection, is this one here, which sits right on, in fact, looks like it's invading the mesorectal fascia. So there was concern, but our radiation oncologist felt that she could easily include this in her field and buzz this area and sterilize this node potentially. So yes, so a good question. So it is, they're bulky lymph nodes, and if they all turn out to be metastatic, they are threatening the CRM.
Okay, thank you. Izzy Obokare has his or her hand up.
Yes, I want to say a big thank you, sir, for giving the opportunity to ask this question or bring this up. This is Izzy Obokare from Amarillo, Texas. I'm a colorectal surgeon in the US. In fact, I had a patient similar to this just about less than 2 months ago, a younger patient. But this patient, I think the concern here is the circumferential margin and also the metastatic disease, potential metastatic disease. To be able to get a complete resection on this patient, or to get an R0 resection, one has to put into play looking at the metastatic lesion that has to be treated with systemic chemotherapy. The local lesion too has to be treated with radiation chemotherapy as well. But I think ultimately this patient may end up requiring an abdominal perineal resection just because of the extent of the disease, the proximity to the sphincter, and the potential for post-op complications if the patient is put back together with a low anterior rectal syndrome. So there are many factors to consider. I think this case really highlights the importance of having the MDT in place, where all the parts and all the specialists can work together to help this patient out. Thank you.
Yeah, thank you very much, everybody. Just one point, Mr. Ahmed, you didn't say anything about the MDT coordinator in your presentation, or did I miss it?
I did actually. I called them facilitator. Maybe that's why. But
okay.
Yeah, so they are a huge part of, and I think it was on my. Let me see if I can find my.
Oh, it's okay.
My slide about the MDT.
Yes.
Yeah. So yeah, they are a huge. I mean, I work close. I don't know how we would do it without them. You know, they are. You know, they're absolutely vital to. I think I did miss them off this slide, so I do apologize. I had another slide that was in a circle with the facilitator in the middle, which is what exemplifies what they're supposed to do. So yeah, no, they're absolutely vital. You can't do this without a facilitator. And in many places, it is left, particularly my experience in Nigeria, it is left to the residents in the department to put the meeting together, make sure everything's available. And you need somebody who's doing this full time. You know, it's their job to make sure it can be that you get a nurse who combines that role. And we've got to do things that are possible to do in Nigeria. But you need somebody whose job it is dedicated to do this all the time. You're absolutely right. Thanks for reminding me.
Thank you. Right, Mr. President, sir, we're 5 minutes. I do apologize. We're 5 minutes beyond the allotted time, but you will agree with me that it's been a really very interesting discussion and a nice exposition on how discussions at an MDT should be had. So I'll hand over back to you now. Thank you very much.
Thank you very much, sir, for the coordination of the panel session. We really appreciate that, and we look forward to learning from you some other time. I also want to thank Dr. Wadiyeye and the other ESCO members for putting this together, because one of our goals this year is that we want to use as much as local faculties in addressing our local problems. And I think this is one of the things that we aim to achieve. And I want to appeal and implore as many of us in our various centers that we should start imbibing the tenets of MDTs in our patient care. We might not get there in one day. Definitely, we will not get there in one day. But I think little drops of water makes the mighty ocean. So from what we have learned today, if we can imbibe some of these things that we have learned today, and gradually we improve over it, I'm sure it will also improve on the outcome of our treatment protocols for our patients. I thank everybody that has made it possible for this to happen today. I also want to thank the ACGPI representatives, Edley and Sanjay, who were here earlier on to discuss with us the concept on coloproctology training. Before I close, I don't know whether Dr. Igwari has one or two things to say, and I can see Dr. Adeye's hand up. Before I go to Dr. Igwari, please let me just use the next 3 to 5 minutes to leave the floor open for comments from some of our trainers. Professor Ugu, I'm sure Professor Ugu is in the house. I can see Dr. Oshinowo. So let me start from Dr. Oshinowo. Dr. Oshinowo, just 30 seconds to make a comment before we close for the day.
Okay. Good evening, everyone. Good evening, everyone. I think I had an MDT. I think we had a seminar about, was it in April this year, which in Lagos we talked extensively about the importance of MDT. Unquestionably, MDT is very important in managing most of our colorectal cancer patients, especially in Nigeria. We all know most of our patients present with advanced disease. The virtual fact that they present with advanced disease, it makes it critical for us to ensure that all of the patients with advanced disease are managed in an MDT setting. It makes it a lot easier because advanced diseases are complex to manage. Advanced diseases are complex to manage, especially the rectal ones are very complex to manage. The case they just discussed in Nigeria, what I probably would have done for this patient would have been like the radiologist, the oncologist mentioned. Patient will have had radiotherapy and neoadjuvant chemo. Highly unlikely this patient will end up being operated. I doubt it. Thank you, everyone.
Thank you very much. Professor Zoilo, can we add a word from you, please?
Highly unlikely
Professor Zoilo.
End up being operated.
Professor Zoilo, I can.
Thank you very much. I think this has been a most wonderful session. I'm sorry I was having network challenges, so I joined in a bit late. But the much I've been able to catch has been very, very enriching, and I'm glad I was able to take part in the part that I did. And I'm looking forward to more sessions like this. Thank you very much, and kudos on a job well done. Please, let's keep it up. Thanks a lot.
Thank you very much, sir. Professor Ogu, over to you, sir.
Thank you very much for giving me this opportunity. I think this discussion is very, very important. Tumor specific multidisciplinary team, I think it's the time has come for us in this country to start now. We are very much behind. And I haven't seen anything that we could not do. So it's more of the will to start. I thank you for this lovely presentation. And I believe from here henceforth, we'll begin to do the MDTs, but tumor-specific MDTs. And perhaps other specialties will look at MDTs too. Thank you very much.
Thank you, sir. Dr. Lasebikan, you have something to say? Dr. Lasebikan.
Yes, thank you. I was actually typing it. It's actually to Dr. Mukhtar. You know, thank you for the broad overview on MDTs. We actually have an MDT running at UNTH at institutions. We have a few that are site-specific, and then a couple of others that just fit into one that is just general, broad-based. So my question really, because I was really intrigued, you know, when you talked about audits and how you're able to audit each year so you can then generally get better. So I wanted to find out what your key performance indicators were and what were your metrics in when you carried out the auditing. I don't know if you mentioned it. I'm sorry if I missed it.
Yes, that's
okay. Dr. Mukhtar, let everybody finish asking their questions so that you take the answers together.
Thank you.
Okay, Professor Okani, you have something to ask?
Yeah, thank you very much. Actually, I always want to be very, very realistic, and then As a local man, I'm a local man because I'm in Nigeria. Most of all these things that are being discussed cannot be done in Nigeria. Like PET scan. The last time I think I remember I sent a patient to that. She had to get her booking for after waiting for my 1 month. And I think it's only one place that can be done in Nigeria. Not everybody can afford it. So in this type of setting, I keep maintaining that. As a pathologist, the fear of metastasis not that high. Like everybody, like if you want to do a needle biopsy on breast biopsy, that's a malignant breast tumor. Somebody will be afraid that sticking a needle here, it can metastasize. Even ordinary doing fine needle aspiration or even for like doing curve needle biopsy, people will be afraid. It doesn't just happen that way. I want to know what can be done for this patient in Nigeria. Where all these even MI2 for a patient to even afford to do CT scan is a problem sometimes, not to talk of doing CT scan and going ahead to do MRI and even going up to do PET scan and all those stuff. These things are not feasible. We want to bring this thing home. We are in Nigeria, and I think we should discuss things that most other people, most surgeons in Nigeria will also learn from and even do something about. The Dr. Lash said something very important. Use of adjuvant chemotherapy and other things, and even Dr. Mukhtar says. But what can be done? Let us get this thing home so that we can, in as much as we are talking about international standard, how to manage all these things, we should also bring some caveats on how we can help our patients in Nigeria, where we have more resources. That's my only input. Thank you very much.
Yeah, thank you very much, Prof. Dr. Adeyeye.
Thank you, sir, for recognizing me. I just wanted to bring your attention that we had planned to share some results from the survey. Do we still have time for that, or should we make that on that day?
Well, I think we are running out of time. Maybe we make it at another time.
Thank
so
you.
let me allow Mr. Mukhtar to handle the questions that have been raised.
Yeah. So with regards to the data set for the audits, we have the National Bowel Cancer Audit, the MBOCA in the UK, which guides the data. We collect a huge amount of data, which is published nationally. It goes down under three broad categories. The first one is about monitoring the performance of the MDT itself. So one of the important ones is the patient being provided a clinical nurse specialist or clinical nurse specialist being present when the patient is given their diagnosis of cancer to act as support for them. And we're meant to achieve 95%. So that's one of the sort of those aspects that are not the clinical side of it, but actually as the MDT as a team functioning as it should. Then there is documentation. So for example, have we documented the height? So for rectal cancers, one of the KPIs is documenting the height. I can't remember the number for audit purposes, the metric, but we are meant to record the height of a tumor rectal cancer above the anal verge, because we know it plays an important role in making decisions about sphincter preserving surgery, for example. There are so many other things, for example, your recurrence rates, the radiation rates. So it's monitored. So trusts that are seen or hospital centers that have a lower than the national level of radiating rectal cancers are highlighted, because we know that when your radiation rates start to drop, often you would see a rise in positive margins. And again, the positive margins, again, your other indicators, your rate of R1 resections. So there are quite a few. And of course, in the documentation, there's performance status, which is really important. And it was mentioned by a few people that last patient with rectal cancer was put down as performance status 1, in spite of his comorbidity. So it goes under three broad categories. First is the performance of the MDT. Second is documentation of what you've actually done or what you do. And the third is the clinical performance indicators, such as resection margin, the percentage of patients that had minimally invasive surgery, for example. So, and then access to clinical trials. So there are access policies, and you can select which ones you would report. We don't report all of them every year. Some are mandatory, some are optional. I can't remember another question. No, that was the only one I caught.
Okay, thank you very much, Mr. Mukhtar, for the answers you have given. I would like to say that if there are more questions, we can post them on our WhatsApp group so that we can continue the discussion over there, because we are actually out of time now. And I can see that there are almost like 14 questions on the chat page. We can post these questions on our WhatsApp page so that the discussions can be ongoing there. Likewise, I think the survey outcome, Dr. Adeyeye, we can actually post it and discuss it on our WhatsApp group during the week. I think that would be better. Once again, I thank everybody for attending this meeting. It's been a nice outing for the month of July. By this time next month, we shall be having another edition of this meeting, and the advertisement will be out in due time. I think sometimes next month we should be having the privilege of hosting Dr. Wexner during our meeting, but we are still going to finalize the details and get back to the general house. Thank you very much for attending to this meeting, and I wish everybody a nice week ahead. Thank you and goodbye.
Thank you very much.
Thank you.
Thank you. Bye.